My goodness, thank you for all those kind introductions and shout outs this morning. So I first want to say that I'm really grateful for that case and for the patient who came earlier this morning. That's a very brave thing to do, both for the patient and for the clinician. I'm going to reference the case that we just saw in my talk, and I'm also going to talk about issues that may not have been brought up by the case, but I think are common in this area. And I do this in no way to critique people's practices, but just to help us reflect and learn how we might apply some principles to other patients that may come next. So I hope that's helpful. All right. So I just wanted to, I just want to make sure, is this the version of the slides from this morning? It is. Okay, perfect. Just wanted to double check. So I just wanted to tell you a little bit about the background that I bring to this, just so you understand kind of the perspective I take. So I'm a general internist. I also trained in infectious diseases and palliative care. I trained at Mount Sinai with Cardi and Sean and others who are in the room. And I'm also an addiction physician. I practice addiction medicine. I run a chronic pain clinic for people living with HIV, and I'm a behavioral scientist. So these are the backgrounds I bring to the discussion I'm going to have with you today. Okay, so the order I'm going to take here is I'm going to go through some definitions. We've heard people talk about pain and chronic pain, addiction, serious illness this morning, but I'm going to break down some definitions as I feel like they apply to this discussion. And then I'm going to talk about the state of the science in this intersectional area between chronic pain, illness, serious illness, and addiction. And then I'm going to dive right into the clinical challenges that we've already heard on Twitter, that we've seen in the case, which I think is a fantastic case in its representation of the issues that are really out there. And I'm also going to talk about clinical challenges that I hear from my colleagues and I see in my practice. Okay, so what is chronic pain? So chronic pain is distinguished from acute pain by time frame. So this is pain that lasts for at least 3 months. It's common in the general population. So I realize when I give talks like this that probably about 10% of the people I'm talking to have some kind of chronic pain. It can result from initial tissue injury, as we heard about this morning, and also not. So what I mean by that is you can break a bone, you can have a painful rheumatologic disease that involves inflammation, and that can lead to ongoing pain, even when that initial injury is over, even between exacerbations of your rheumatoid arthritis, let's say. But then there are also times like chronic low back pain, fibromyalgia, where the brain is getting a strong signal of pain, even if there's nothing going on in the periphery. And then we really think, as a pain physician, I will say, we really think of most chronic pain as existing in both of those areas. I have a soundtrack now to my talk. Fabulous. Okay. So the other thing I want you to think about is I want you to think of chronic pain as a chronic disease in and of itself, not as a symptom, but a chronic disease in and of itself, which means that it's heavily influenced by biological, psychological, and social factors. So I will hear often from clinicians that chronic pain is this mysterious thing that we don't understand what causes it. There are entire departments, conferences, organizations that are dedicated to the biology of chronic pain. And very simply, oversimplified, it involves hypersensitization of peripheral receptors. It involves processes in the brain and the spinal cord that perpetuate this ongoing process of pain. In addition to that, there are psychological factors. So chronic pain can lead to depression. Depression can make pain worse, for example. And social factors. People with chronic pain are more often socially isolated. Social isolation can make pain worse. And the optimal treatment for chronic pain, and this is a vast oversimplification of an entire field, but it's pharmacologic and non-pharmacologic. So medications, including opioids, but also not opioids, and things like behavioral treatments that we heard a little bit about this morning, and is best offered in a multidisciplinary way. We heard about this morning from Dr. Liebschutz. I want to remind you, addiction is also a chronic disease. It is a brain disease. We know a lot about the biology of this. I like this idea of it's a hijacking of the pleasure-reward system in the brain. It can exist to many different substances or multiple substances all at the same time. And the cornerstone of treatment is really medication and, when available, psychosocial therapies as well. I'm putting this again up here, I knew Jane was going to have this in her talk, but I wanted to remind you that addiction, or as we call it medically, substance use disorder, is a disorder of behaviors, of inability to control behavior. So it's not just use of alcohol or use of opioids, it's in a way that the person cannot control. It's taken longer periods of time, they can't cut down, they spend a lot of time getting it, they crave it, they can't fulfill major role obligations, it disrupts their social life, interpersonal relationships, and they do it despite knowing that it's harming them. So this is a compulsive disease, really characterized by that lack of control and compulsion. Okay, third definition for us is serious illness. So we've alluded to this all morning. We've talked about people who have serious illness, but I want to take a moment and say what this really is and how I'm going to refer to it in my talk. So serious illness is defined as a health condition that carries a high risk of mortality. So there's some idea that maybe prognosis is shortened, but people are living with this illness. As the patient said in the case that we just saw, she's living with cancer, not dying from it, right? And it negatively impacts a person's daily function or quality of life and or excessively strains their caregivers. So there's a diverse list of potential chronic illnesses. We've heard a lot about cancer this morning, which is appropriate, but also other chronic illnesses, COPD, heart failure, renal failure, ALS, this multimorbidity, this idea of multiple comorbidities together being greater than the sum of the parts. So a very diverse group of illnesses that, as you can imagine, are often associated with pain, right? Okay, so we've talked about chronic pain, we've talked about addiction, we've talked about serious illness. Why are we talking about all these three things together? How does this occur? So there are a lot of different ways that chronic pain, serious illness, and addiction can come to intersect in a given patient, right? Chronic pain and addiction are both common. We've established that. And so people can come into their serious illness already having one or the other or both, right? Our patient this morning talked about coming in with already having had addiction, right? And we know addiction is a chronic relapsing remitting illness, so she came in with that diagnosis. Pain and addiction often occur together. So in studies at methadone clinics, for example, prevalence rates of pain can be upwards of 80%. So pain is common in people with addiction, but then also addiction is very common in people with pain. They don't always occur together, but more commonly than the general population. Substances, including opioids, are used to treat pain. So, and these substances can be powerful triggers for addiction in people who are predisposed to it, in people who have had addiction before, or even in somebody with no history, right? Pain is a common complication of serious illness, right? So as somebody develops serious illness, they may then develop pain. And people with serious illness are living longer, which is wonderful because of new treatments we have in all the different diseases that I mentioned. However, this means that they have more of an opportunity to develop pain and addiction, right? Longer periods of time. And serious illness, I don't have to tell this audience, is a period of intense stress, right? And stress can be a very powerful trigger of addiction. Okay. And it can exacerbate pain too. All intertwined. So the result of all this is individuals who have serious illness who have both chronic pain and addiction. That's why we're having this discussion. Okay, now I'm going to spend a few minutes talking about the state of the science in this area. So there's very little literature, despite this being such an important clinical problem. You turn to the literature, there's almost nothing. So the focus of the literature that is out there is in patients with cancer in oncology and palliative care settings. So studies of clinics who take care of patients with cancer find that they do not screen patients for opioid misuse risk or substance use, so screening is not common. And when they do screen patients, these are all from studies of cancer, they find an elevated opioid misuse risk, elevated unhealthy alcohol use, substance use disorder diagnosis about 6%, so that's significant. And concerning drug screen findings in up to half of those tested. So it seems like this is a problem in the, it's not that there's not an issue here, it's that we really haven't studied it yet. And very little literature on management approaches. I mean, you can hear that from the Twitter storm of questions on this topic, like what do we do? This is not an there are no evidence-based answers really to this at this point. We've also heard mention palliative care. Many of us in the room are trained in palliative care. I just want to make mention of what this is. For those who may not be familiar, palliative care is specialized medical care for people living with serious illness that focuses on providing relief from the symptoms and stress of a serious illness to improve quality of life for the patient and family. So pain management is well encompassed within palliative care. And so therefore, individuals with serious illness who have pain and addiction, as Dan said in the case, often present to palliative care settings. So as a result of this, we actually conducted a study, a national study of members of palliative care professional organizations, and asked them the question about patients who are cancer survivors who have chronic pain and are not at the end of life. Basically, the patient you just saw, this sort of prototype of a patient. So we asked them to think about that type of patient, and we got mostly physicians and nurse practitioners to respond, as you would imagine. And we asked them about what their practice is like in managing these types of patients. And among other things, they told us that they spend a lot of time managing opioid misuse behaviors. We'll talk in a moment a little bit more about what misuse behaviors are, and one of the Stephans this morning mentioned this as well. But the idea is that, managing people taking more opioids than prescribed, having multiple providers, going to the ER, concurrently using illicit substances, they spend more than half of the people who responded to the survey spend at least 30 minutes every day managing this. Okay, so this is a big issue, right? Of all the things we asked people whether they had confidence in, like their ability to prescribe opioids, their ability to issue non-pharmacologic therapies, et cetera, the thing that they were least confident in their ability to do was to manage addiction, 5 on a scale of 0 to 10. Only 27 reported training or systems in place to address addiction in their practices, despite how important it is. And only 13% were DEA waivered to prescribe buprenorphine, one of the 3 FDA-approved medications for opioid use disorder, and 36% had no access to an addiction specialist whatsoever. So clearly a big issue. So my colleagues Tim Quill, Yael Shanker, and I earlier this year said, gosh, given this limited evidence base, what are we to do? What as a field do we need to do to take the next steps in really thinking about this? And so we wrote a piece that really talked about research, education, and policy next steps that we might think about. And we said that we need more research in serious illness on assessing opioid risks and harms versus benefits, that tension that we heard a little bit about this morning, other analgesic approaches and their application to this population, whether that's medications or things like CBT, how to manage concerning behaviors and addiction in patients with serious illness. And we also need efforts in education and policy around these issues. We heard several times that even palliative care physicians who encounter these issues a lot have not been, don't routinely receive addiction training. I think that's changing a little bit, but still remains a big issue. Okay, so now I want to dive in to what I think the frontline clinical challenges here. This is not an exhaustive list, but these are the things that tend to bubble up, either bubbled up in the case that we just saw or among questions I receive from my colleagues. So what's a clinician to do? The way that I have thought about this in my own practice and in preparing for this talk is to really think about, as an addiction physician, as a general internist, as a pain physician, what do those literatures bring to bear on some of the questions that come up? Even though we don't have a literature in that intersection area, what do these other literatures bring to bear on these salient questions? So here's just a little question, minor thing. What is the optimal treatment for chronic pain in individuals with serious illness, with or without addiction? Just how do we treat chronic pain in patients with serious illness? And I think one thing that I want everyone to think about is sometimes treatment of chronic pain and opioids get conflated in the way that we speak about things, okay? So, and I even heard that a little bit this morning. So I want everybody to remember there's quality treatment of chronic pain, which we'll talk about what that might look like in a second, of which opioids may be a part and many other things may be a part. But oftentimes inherent in a question like this is really the subtext of, so how do we decide who gets opioids and who doesn't, which can be an important part of the question, but is not the whole question, okay? So from the chronic pain in general medical literatures, I already mentioned, the standard of care combines both pharmacologic and non-pharmacologic treatments. The best treatment models, evidence-based treatment models, have been shown to be multidisciplinary. They're often very difficult to access because they don't exist that much due to insurance, essentially, like due to lack of payment structures that facilitate them, but that is the evidence-based model. And from the chronic pain and cancer literatures, we heard about the CDC guidelines. They have their limitations, but both the CDC guideline and Dr. Judy Pace, who was the lead author on the ASCO guidelines, really talk about this risk versus benefit paradigm, which really should apply to any treatment we issue for any patient. But really, when we think about opioids, you really want to actively think, what are the risks, what are the benefits and harms, and weigh them with patients at every visit. And of course, addiction is part of the risk side of the equation. And when you consider that, you consider individual factors like history of addiction, but also just that addiction to opioids can occur in anyone, okay? So we heard this in the case. What about patients with legitimate pain, right? Sometimes people will call that organic pain or real pain. And what's often meant by that, I think, is pain that shows up on an x-ray somehow. So patients without malignancies, it's often like, oh, they have, degenerative disc disease. We can see it on the MRI. It can be used to talk about patients with cancer who have, say, like bony mets. Like, of course, that would cause pain. That seems legitimate. Patients with inflammatory conditions, that's, we can see it when you examine them. So the question really is the distinction between organic and other pain a useful one, okay? And does having organic pain equal opioids, right? So from the pain literature, I think the message is very clear. This terminology and distinction is essentially disappearing. So chronic pain is not a symptom. Inherent in a lot of this is this idea that chronic pain is a symptom of something, but we just talked about how chronic pain is its own chronic disease. It's perpetuated by biological, psychological, and social factors. That's true for somebody with chronic low back pain. It's true for somebody with cancer. It's true regardless of what that initial pain generator was, or it continues to be. And so I would encourage people to think about organic pain, quote unquote, not necessarily meaning that a person needs or deserves or whatever the language is that I've heard, opioids. It's one needs to assess the risk versus benefit of opioids, and again, not conflate opioids with good quality pain management for sort of deserving real pain, but rather not miss the fact that all these other elements of treatment for chronic pain are still applicable, okay? All right, another one. Does the patient have pain or do they have addiction? Okay, so there's a concept called pseudo-addiction that some people here may be familiar with, which is this idea that somebody may be continuing to report pain because we're not, and exhibit behaviors that may look like addiction because we're not giving them enough pain medications, and the solution then is to give more pain medications and then these behaviors disappear. So with that concept kind of thrown into the mix, does the patient have pain or do they have addiction? So from the pain and addiction literatures, pain and addiction frequently coexist. So the answer is maybe yes, they have both. That can happen. They may have one, they may have the other, they may have both. Pseudo-addiction, again, in the pain and addiction literatures is becoming a less than useful concept because there's really very little evidence base behind it, in addition to the fact that there's no reason why pain and that these behaviors can't mean addiction, and that one shouldn't investigate whether that patient may also has addiction. So this is something that we all have to unlearn. This is a very prevalent idea that we all need to unlearn. So then, what is the best approach to management of concerning behaviors that arise in individuals on long-term opioid therapy? So we heard some of them in the case where, it sounds, they mentioned unexpected urine drug screen results, for example, using more opioids than prescribed. We heard that from one of the Stephans this morning about taking 6 rather than 5. There's a long list of these types of concerning behaviors. I just mentioned 2 of them: missing appointments, taking opioids for symptoms other than pain, other substance use, et cetera. So the purpose of this slide is not to go through this algorithm, but to say that myself and Dr. Liebschitz and several other colleagues recently conducted a Delphi study where we asked experts how they manage these types of behaviors, not in patients with serious illness, but in primary care settings, and came up with some consensus around what to do. And the noteworthy things from this are that it's complicated. Look at that algorithm. It's got a lot of branches. And it really involves a first step of trying to figure out the differential diagnosis of the behavior, trying to re-educate the patient about the importance of taking opioids safely or not, using illicit substances or whatever the issue may be, trying to understand if there's a pattern present, and if that pattern means that there's an opioid use disorder. And if the patient has an opioid use disorder, that is a disease that needs to be treated. Just like if you discovered the patient had diabetes somewhere along the way, you would treat it. It's the same thing. So identify this other chronic disease that I think is often missed in this setting, okay? So this is really complicated. How do you diagnose addiction in individuals on long-term opioid therapy? So actually, let me take that away so it's not distracting you. Oh, I can't. Well, too bad for me. All right. So we put up the DSM criteria, Dr. Liebschitz and I, and you might notice that those DSM criteria were really developed for people who are using opioids from non-medical sources. But when the physician, for lack of a better way of putting it, is the source of the opioids, the drug dealer, then we start to see some behaviors that we're not used to seeing. And so the question becomes, how do you recognize some of those behaviors that represent loss of control in somebody who's coming to you, the clinician? And so this is some work that we're currently working on from that Delphi study as well. For example, could it be that using more medication than prescribed, taking non-prescribed opioids, is the same thing as larger amounts and longer period? You know, is that really what we should be looking for in our patients? ER visits, multiple prescribers, multiple pharmacies. To me, that signals people are spending a lot of time to obtain this. If I'm the fifth person you've seen this week, you've really spent most of your time this week in pursuit of opioids. Now, does that mean that you're having really severe pain and you're doing a good job advocating for yourself? Or does that mean that the substance is what's driving this? That is a very difficult thing to determine, but it's worthy of determining, okay? All right. So back to the case for a minute. So there are a couple of things I heard in the case that kind of perked my ears up. So one was when Kelly said, for the first 3 hours of the day, I can barely function, okay? And then she says she can tell when it's 3 p.m. Now, I'm reading a little bit between the lines here, but to me, that sounds like it could be craving. It could be a little bit of loss of control over her function related to having or not having opioids at that moment, okay? And she also says she's trying to make 6 last. So is that compulsive use? Is that pain? Is it both? Is pain a symptom of craving, which can happen? What is really going on? And she says she tries to make 6 last, but she's not always successful. So maybe that's the loss of control piece. She's doing the best with what she's got. So what this signals to me as a question is this a partially treated opioid use disorder? I don't know. I've only seen what I've seen in this case. This is a diagnosis that oftentimes in situations like this I make over multiple visits with people. It can unravel over years, honestly, sometimes. But making the diagnosis is the first step to treating it. A few other powerful quotes from the case. We heard both Kelly and Dan say, sensitive issues, her history. She said, when I screw up. Dan said, knowing when someone screwed up, but yet we want to take care of them. Dirty urine, bad decisions versus the right thing, adversarial positions, policing, etc. So why do I bring these things up? Okay. Again, this is not to critique. This is for all of us to think about. So this is stigma. There's stigma that's self-imposed. She used this language as much as he did or more, and a lot of times he reflected it back to her, right? So what can be helpful here? I mean, we could have a whole symposium just on stigma and addiction, so forgive me, but I think one thing that can be very helpful here vis-a-vis what we're talking about is naming the disease. Does she have an opioid use disorder? Is that part of what's going on here? She had an opioid use disorder. Does she still have an opioid use disorder? It's a brain disease, so not framing it as good or bad or something to be policed. Why does this matter? So we know that patient outcomes are worse when we use stigmatizing language. Patients are less likely to present to care, et cetera. This is not about political correctness. This has real implications. So I've listed up here for your perusal some language that can be stigmatizing and then alternatives. Instead of abuse, use disorder. Instead of toxicology results being clean or dirty, positive, negative, unexpected, et cetera. So how do we treat patients with pain and serious illness? And should this be different than how we treat, or how do we treat addiction, in patients with pain and serious illness? Should this be any different than how we treat addiction in anybody else? Like, what are the factors that might make you consider doing this differently in this population? I mean, the real answer is we don't know, right? We don't have the literature to support this. But from the addiction literature, we know, like Dr. Liebschitt said, treating addiction save lives, it increases quality of life, and the mainstays of treatment are medications and psychosocial treatments. In this case, she's being prescribed methadone for her chronic pain. Methadone also has a role for opioid use disorder. So I see this come up a lot. I think that this is a really important question clinically. So in somebody like this, what is the efficacy of buprenorphine versus methadone for pain, but also for addiction? We know that methadone clinics, as Jane showed earlier today, are separate from the rest of our general medical infrastructure, right? Office-based methadone in the US is not a thing. Should it be? I mean, would that be a good way to treat somebody like this? Perhaps. So this is a study I want. I want to do this study. I feel like I feel like we need to know this and we need to know it now. Where should addiction treatment occur? At the specialist's office? Palliative care, primary care, somewhere else? So this is easier said than done, so don't jump on me for that, but everywhere. There aren't enough addiction specialists to meet this need. Not everybody can go see an addiction specialist. It's just not possible. From the general medical literature, we need more education of all kinds of frontline clinicians who can pitch in and help with this. How do we balance compassion with managing addiction? This sort of came up a little bit in the case. Compassion does not equal opioids. Treating addiction is compassionate and addiction is suffering. So I'm going to skip this slide in the sake of time, and I'm going to just leave you with this thought. So this is an oldie but a goodie from around 2000 from our colleague Steve Hasek, who said, he wrote an article, part of the title was Why Bother to Treat Addiction in Patients with, he's talking about cancer, but serious illness. These are the reasons, okay? Increased patient suffering, increased stress, masking of symptoms important to the patient's care, poor adherence to the medical regimen, decreased quality of life. And he said, why bother to assess and attempt to manage addiction in cancer patients? Those of us in psycho-oncology and palliative care have among our missions the limiting of suffering and the facilitation of adjustment to life with cancer, serious illness. Ignoring or being passive or fatalistic about drug use does not improve quality of life and runs contrary to our goals of care. So to sum it up, managing chronic pain and addictions in individuals with serious illness is challenging. However, it is important, and I will also add, very rewarding. We are here today because we are thought leaders in these issues, so who better than us to find a way forward to improve care for these patients? Thank you.